Thank you so much. Every time I hear about Kerala's programs, I'm always amazed by how diverse and really taking a very holistic approach to this. But thank you for highlighting also some of the gaps and the steps taken in the new policy to fill those gaps. But one of the points you raised was really about the tools and the assessments and how we really identify which persons, what is the situation of older persons requiring care and support. So we're really honoured to have probably two of the regional experts in this issue to explain a little bit more about some of the current thinking, research and principles behind these. So first I'd like to invite Dr. Wai Chong, who's the founder of NYC Longevity Practice Singapore. Many of you know him in the region, and he is a practicing aged care physician with a long experience of community caregiving and clinical work in this area. So over to you, Wai Chong. Thank you.
Thank you, Meredith. So can I have my slides, please? So while waiting for the slides. Okay, this is my slide. I have only 5 minutes, so this is one slide. And yeah, so well, just to let you know, actually I only have 5 points to make. But yesterday I was receiving Ayurveda treatment. So the hot coconut oil was dropping on my forehead. And then I have this vision, so I'm going to share with you. And to answer Eduardo's challenge this morning, he wanted us to talk about the how and not just merely about awareness of the issue. So I'd like to share with you my hypothesis about how we can integrate health and social services. So the question is how to integrate health and social care for the frail person with unmet needs. So I like to scope it to people who need care. So I like to use Rockwood's clinical frailty scale because it's based on the frailty index, which our Kerala Assistant Secretary spoke about just now. So we need to understand that we're talking about people who need care, not the usual active agers that many of us here belong to this group. But we know that frailty is a spectrum. So in order to have integrated care, the most important person, of course, is the loving carer. So of course we can have people engaging in formal caregiving, but then again, you want somebody who really love you. So caring is a love language, so we don't want to deny that. So it is always important, especially in Asia, that family carer always have a place in integrating health and social care. And we are talking about home and community care, so we need to know that people live in a human habitat, that is a home and community. But what is a home? So is Mary Ann in the room? Last year, she wrote an article about home, and she defined home as a place that you can be free to be yourself, a place that you feel connected with your past, a place that you feel safe and comfortable, and a place that you have relationships that are meaningful. So that is home and community. So even though we are talking about formal services, we must not forget the human habitat that the person is living in. Then of course, we know all of us, especially when we talk about long-term care, we need to build services, health and social services. But I'd like to add a term, accessible at the front and of high quality at the end. So it's about accessible home and community, health and social services of high quality. So what is accessible? So I take reference from a research that ILC did a few years ago. We talked about the 6 A's. What is accessible? The European Patient Forum defined accessibility as 5 A's. It has to be available, it has to be affordable, accessible, appropriate, and adequate. Some people would argue you add another A, awareness, acceptable, accountable. But then let's just keep it at 5 A's. What about quality? So the AHRQ, the Agency for Healthcare and Research Quality, healthcare research and quality, have these famous 6 domains of quality, which are safety, effectiveness, person-centeredness, equitability, timeliness, and efficiency. So those are the 6 domains. So even as we build the community services of health and social care, we need to look into accessibility and quality. But, you know, me as a doctor, I know doctors in the specialty, in the hospitals, in the private hospitals, in the public hospitals. Doctors think in a certain way. They think disease. They do not want to talk about the drama of psychosocial. They want to deal with the disease. So, but if you have got health and social services with different ideals, ideas, principles, values, it's very hard to integrate. So I would argue that common value is important. Everybody, in order to integrate, need to believe in focusing on the spirit, in teamwork, in growth and development. Even if a person is dying on her deathbed, there is always growth and development. So this is a value that we need to harmonize in order to have effective integrated care. But we must not forget that all this has a background. And what is the background? Infrastructure, economy, which is related to policies, which is related to politics, which is related to the society, which is based on the culture. And I missed two more points. Culture is dependent on civilizations. Civilization dependent on history, dependent on climate, dependent on geography. So it's different parts of the world will have different understanding of what aging means and what caregiving really means. So we need to respect the background. So finally, I want to talk about the how. So it begins with a person-centered comprehensive needs assessment of high quality. So what do we mean by comprehensive needs assessment? What are needs? So it's being covered there. Needs equal goals divided by strength minus weaknesses. Imagine if you are a senior person who is so at peace, you have no desires, you have no needs. But of course, we are not perfect. We have a lot of needs. So needs equals strength minus goals. I remember yesterday, Dr. Amy Kiyota talked about, we do not just want to assess for weaknesses, we also want to assess for strength. Goals, strength, and weaknesses are part of our comprehensive needs assessment. But we must not forget the caregivers have unmet needs too. So now the Inter-RAI community, which I'm part of, we're now developing an Inter-RAI self-report carers needs assessment. Is very important. But how do you frame carers needs? It's not just caregiving related needs. The carers themselves have their own needs, the biopsychosocial health. So you need to have a framework to assess the needs. And then you can have a one care plan for the older person and the carer based on the comprehensive needs assessment. So this one care plan is to be used by those in the bottom, the community health and social services. So with this care plan, so this standardization of comprehensive needs assessment is really, really, really critical. Recently, Singapore has just decided to mandate the use of Inter-RAI. Why? Because aging is so urgent and is so complex, you need to standardize your assessment so that you can assure quality of care as well as quality of your data, which is so useful in informing policy and identifying gaps. But case management is not just CNA. You have to expertly coordinate the resources and implement the care plan. You have to play the role of a person who can bring people together. That's how you integrate health and social care. And so then you need to have the skill to communicate and have to establish a trusting relationship with the care recipient and the carers. So this is, in red, integration. Integration equals case management with a face. I just came from Mustang, Nepal. What I noticed was that the case manager is a traditional Tibetan physician. In the olden days, it is a general physician who visits the homes. Nowadays, doctors are too expensive, so we use either nurses, social workers, and sometimes we train volunteers to do this. So finally, I would summarize by saying that this is actually, okay, we integrate by understanding the kitchen. And then we need to know what are the ingredients I have in the fridge. If it's not there, I need to go and buy. And as a chef, I need to understand my audience in order to create a meal. So this is how we integrate care, and the chef is the case manager with a face. Thank you.
Thank you so much, Wai Chong. But can you explain what is Inter-RAI?
Okay.
Because you just Briefly.
Okay, Interact is a non-profit group of nerds. They are researchers, they are mathematicians, economists, doctors, and so on. It is actually a group of people who want to get the best of data so that they can scientifically, rationally, really develop good person-centered long-term care for people. And because of that, the data quality, they've got billions of data, and there are lots of evidence-based quality indicators that come out of it, resource utilization grouping that can justify what's the dollar sign to each group of case mix group of persons. And with the Interact assessment, once you do it, the algorithm will tell you what is the functional issues, what are the clinical issues, what are the psycho-cognitive issues, and what are the social-economic issues. And with that, you can actually have a care plan that's evidence-based. And they can come up with scales that replaces your depression ratings, your geriatric depression scale, your AMT or your MOCA, and so on. So you have a scale of cognition, mood, function, behavioral challenges, and so on. Yeah, so that's it, Interact in a nutshell.
Thank you, Aichong. I think we all need to have a traditional massage. That's great, thank you. So to explore a little bit further in these, the tools, the key tools for effective and integrated care, we're very honoured to have Professor Susana Sojourno joining us. He is the head of the Medical Commission at the Universitas Indonesia, and he's an advisor for many organisations, including Indonesia Geriatric Association, Alzheimer's Indonesia, Indonesia Dementia Care Association. And he's currently working as a geriatrician and a lecturer at the RSCM Hospital and the Faculty of Medicine, Universitas Indonesia. So thank you very much, Professor, for joining us today. Thank you. We have 5 minutes.
Thank you, Meredith. Can I have my slides? Okay. Continuing things that has already been presented by the previous speaker, I would like to share you some of the things regarding the comprehensive operational framework for the elderly in the community. There are 5 pillars. If we are talking about elderly, wherever we are, whenever we are going to serve them, we have to remember that we are not talking about the biological issue or physical issue. There are other issues, psychocognitive functions, psychosocial issue, nutritional and environmental. But please not try to forget regarding the functional issue. It is the most important part of the things that we are talking about now. Functional capacity, functional status, that could be assessed either by Bartel Index, ADL index tools, or WHO UNSCAP and modified ranking scale, for example. Pillar number 2, we are not supposed to talk about curative modalities. Essential part of the care is the promotive modalities, preventive for the illnesses, and also rehabilitative modalities. Because we are not going to talk or tackle regarding the decline in structural functioning, but also to tackle the limitation of activity for this particular elderly and try to identify the participation restriction that could be applied in the community. So if we are managing our elder people in the community, we are not only organizing the medications, but we have also to organize the fluid intake, organize the nutritional intake, organize the activity that should be done and not to be done, and also the psychosocial care. So if to some extent they have to be hospitalized, it is very crucial to arrange the discharge planning start from the very beginning so that when they have to come back to the community, they could be functioning as optimal as possible. So once they have already been assessed by either any kind of tools that we are going to use, the ADL Bartel, the modified ranking scale, etc., the elderly in the community could be classified into 3 categories: the independent one, or fit, or robust; the partially independent, or pre-frail, as mentioned by the first speaker; and also the dependent, or frail, from the second speaker. Once they have already been classified into these 3, they could be programmed towards next program according to their level. Oops. For the independent one, they have to exercise, or counseling, or providing the aerobic or muscle strength exercise. And this could be done in the elderly health post. For example, any daycare centers that are usually done by the private sectors. Those who are partially independent, not only exercise and counseling, they could receive the specific nutritional program. For example, counseling in nutrition, and also provide the oral nutrition supplements. And this could be done in the primary health center throughout the nation. In Indonesia, we have 9,000 primary health centers done by the government. And also what we used to call the clinic pratama, or private clinic for the primary care physicians. For the independent or frail, of course, we can do the home visit and home care. And due to this various kind of activity, we need training for carers, for primary physicians, for nurse, public health nurse, for a family member, and also volunteers. The WHO has already been developing the ICOPI, the integrated care for the older people. There are manuals, there are training for this kind of healthcare personnel, so we can use it. To ensure that these programs will run smoothly and established, maybe we have to apply some evaluation, objective evaluation, by using some indicators. For example, whether there is a specific decrease in hospital admissions rate, for example, or the increase of functional status of the elderly. In order to be able to do this very smoothly, we have to do it in an interdisciplinary manners or transdisciplinary manners, with the elderly-oriented approach, whether we are a family member, caregiver, social worker, etc. So this is an example in Bali of the Sahaja Dharma Sejahtera Foundations. After the pilot project led by the Ministry of National Development Planning 2 years ago, doing the screening and classifying the elderly in the community into 3 levels, my friends, geriatricians in Bali community, developed this foundation to help those who need health care, especially those who are financially handicapped and not covered by the national insurance. The core activities are home visit, home care, health screening in the community, and strengthening the elder health posts throughout the Bali. These are some pictures providing proof that they have done so much in the community in Bali. If you want to visit them, I think Dr. Suka here would like to share their community. Okay, thank you, Meredith, and thank you, the audience, for your kind attention.
So yes, we're very grateful to have the 2 experts and really some of the tools and assessments really needed to, one, provide the care and support that older people need, but very much in that integrated, focused, and really in that holistic way that was highlighted in Kerala as well. So thank you very much. We were going to do a deep dive, a little bit further, a deep dive into Indonesia now. If we could have our next 3 speakers, you can, thank you. So we're very honored to be joined today to do a deep dive on some of the initiatives in Indonesia. We have 3 speakers. We have Director Tirta, who is the Director of Poverty Alleviation and Community Development within the Ministry of National Development Planning, or Bappenas, and our hosts today. She is leading on the finalization of the Presidential Regulation on Social Protection Form, on the integration of social protection programs and adaptive social protections, and she manages cross-cutting issues concerning vulnerable groups, including navigating the country's strategy on aging issues and inclusive development. She is joined by Andy Maulana, who's an operations manager from a community care hub, or LLT program. He's joined us from Yogyakarta over in Java, and he's going to really speak about how they implement integrated community care at the ground level. But first, and then lastly, obviously we know that this really takes a lot of coordination and a lot of different stakeholders. And we're really pleased to be joined by, again, you're from Bali, yes? Yes. Nelugede Sukadaya Shah, who is the Director of the Development of the Vulnerable and Elderly Families at the National Population and Family Planning Agency, or BKKBN. As the director, she's responsible for really working on BKKBN's active and productive aging programs and their coordination and support the home and community care and the family caregivers. So we're really looking at how this coordination from national down to local level really then implements and influences on the ground. So first, over to you, Director Tirta. Thank you.
Well, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen, honorable participants, moderator, and speakers of this event. I'd like to share about Indonesia best practice on integrated older people care, and in the community level, it called LLT. Ladies and gentlemen, Bappenas already formulated the social transformation development agenda together with the other transformation, which are economic and governance transformation, to achieve the vision of Golden Indonesia 2045, which adaptive social protection is one of the policy directives to increase the scope of social protection, social assistance based on the vulnerability status of the community, and then social security, and integrate as well with the employment entrepreneurship opportunities for the community, both in the regular condition as well as in the special or crisis condition like disaster or pandemic. And then the issues of seniority and care economy is already accommodated in Indonesia National Long-Term Development Plan 2025 to 2045 that includes a gradual increase in retirement age. Right now, the retirement age in Indonesia is about 58 years old, and it will be gradually increased to ensure the social and economic readiness during retirement. And then also increasing participation of vulnerable groups in the workplace, improving inclusive environment for vulnerable group, and improving lifelong work and entrepreneurship skills. And then there are 5 development programs that support adaptive social protection strategy that includes social economic registration system to provide comprehensive data for planning and programming, and then integration of social assistance, social security, and adaptive empowerment of community, reform of the national security system, and development of care economy for the expansion of social protection and welfare. The last is social inclusion for welfare of social people with disabilities, older people, and other vulnerable groups to ensure that the beneficiaries, including the older people, will get the benefits regarding their improvement in mental and emotional well-being, active participation in society, promote the physical health, community bonds, prevent marginalization, and enhance independence and dignity. Indonesia also already have the care economy roadmap that support the formulation, the finalization of RPJMN, which is the Medium-Term Development Plan 2025 to 2029, particularly in the care economy policy. The development program regarding care economy will be supported by 4 development activities, which are provision of the services, and then development of funding scheme, strengthening community care capacity, and beyond GDP development supported by recognition and protection of paid and unpaid care workers, formal and informal, as well as individuals, communities, and industries policy direction. The third development activities, which are strengthening the community care capacity, accommodates the provision of long-term care and integrated older people care. Maybe we already know from the information before, from the speaker before, that in 2021, Indonesia already have the presidential regulation to achieve the inclusive developing in aging policy through national strategy of aging. The implementation will be done through 5 pillars, and the second pillars, which is increasing health condition and older people's quality of life, it's truly support the increase of coverage on long-term care for older people, or LLT. LLT is the community base that provide services for older people, and it integrates several sectors, include social and health sector together for the older people. And then this is the overview of the LLT. LLT, as I mentioned before, is a community-based services at the community level, and it involves not only the older people, but also younger generation. So it a kind of implementation of intergenerational approach in a long-term care. LLT emphasizes in the clinical intervention through comprehensive need assessment, including health screening by the case managers. And then the system connect the beneficiaries or older people with the services in the community as well as that provided by the institution, including central and the local government institution. These are the photos about the services that can be accessed, including exercises, workout for older people, and then art activities, and of course medical check-up for older people. Thank you for your attention. I hope from this event we can get inputs and then contribution to improve our policy on aging population. Thank you.
Thank you, Director Turta, explaining the plans and how this has been really integrated both into the care economy strategy, really taking that life cycle approach, and into the medium-term development plan. But as you says, it's really based on that community for older person, that integrated community-based services. So Pak Andy, would you like to come and explain how that integration at the community level really works? As Pak Andy, he operates one of the community care hubs that was mentioned by Director Turta. So Pak Andy, five minutes.
Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Mohon maaf kami sampaikan dalam bahasa Indonesia. Bapak Ibu yang kami hormati, saya Andi Maulana dari Layanan Lanjut Usia Terintegrasi. Sebelumnya saya ucapkan terima kasih kepada Kementerian Bappenas, kepada Surveimeter, kepada EDB, kepada National Consultant, kepada Bapeda Kota Yogyakarta, kepada Dinas Sosial dan Transmigrasi Kota Yogyakarta, dan pemerintah Kota Yogyakarta yang sudah mensupport sehingga LLT Wirawreda berjalan dengan baik di Kelurahan Wirogunan. Ya, wilayah kami ada 77 RT 24 RW, ada lansia 1160, sudah kami petakan problem lansianya, ada ADL, IADL, depresi, lansia depresi, demensia. Kami juga mengkategorikan permasalahan lansia ada 3, ada lansia level 1 atau lansia aktif, ada juga lansia level 2, lansia butuh bantuan, dan ada yang level 3 atau lansia bedres. Nah, kami hanya berlima, namun volunteer kami banyak. Ya, kami bekerja hanya berlima, tetapi kami mengintegrasikan beberapa lembaga berkaitan dengan penggiat lansia untuk ikut dalam kegiatan ini. Nah, yang kami lakukan adalah melakukan yang pertama kegiatan lansia aktif, sama dengan kegiatan pada umumnya, ada menyanyi, memasak, pelatihan-pelatihan, kegiatan, ya. Lalu ada juga yang di level 2 kita lakukan, yaitu lansia butuh bantuan. Nah, kami antar karena mereka membutuhkan bantuan, anaknya bekerja, anaknya sibuk, kita antar untuk sekedar hanya potong rambut. sekedar hanya mengambil obat. Nah, ini kami layani untuk kegiatan-kegiatan pelayanan level 2. Nah, kami fokus adalah di level 3. Ini tidak banyak lembaga yang menyentuh kaitan dengan level 3 atau lansia betres. Kebanyakan lembaga hanya yang disentuh level 1. Nah, ini kami mencoba untuk mengintegrasikan yang di level 3 adalah case management, memberikan layanan yang terbaik untuk lansia betres. Karena lansia betres ini betul-betul membutuhkan bantuan yang cukup. Nah, termasuk pelayanan-pelayanan yang nanti pada slide Bapak Ibu bisa melihat. Nah, ini bentuk active aging program hampir sama pelatihan-pelatihan yang ada di kita untuk menjaga agar lansia tidak masuk dalam level 2 atau 3. Mereka diberikan kegiatan, termasuk kegiatan-kegiatan di ekonomi produktif. Nah, untuk care and support, lansia level 3, ini memang butuh bahasanya Pak Agus dari Bapeda, nah ini, butuh orang-orang gila, butuh orang-orang yang tidak memikirkan apa-apa. Karena lansia level 3 seperti Bapak Ibu lihat dalam foto, mereka, mohon maaf, badannya sudah kotor semua karena tidak bisa jalan, dia membuang kotoran di tempat, kami harus memandikan termasuk rumahnya yang kami setiap hari harus bersihkan. Nah, ini tidak semua orang mau menyentuh. Bahkan saya sendiri bila masuk ke dalam rumah harus memakai masker berlapis-lapis. Karena mohon maaf, takut mual begitu. Nah, muntah. Nah, lalu kami juga menyediakan atau bermitra dengan beberapa layanan untuk mengantar ke layanan-layanan kesehatan. Baik itu berobat, kontrol, maupun apa saja yang diperlukan. Nah, LLT tidak akan bisa berjalan tanpa layanan terintegrasi, melibatkan banyak hal, banyak volunteer. Salah satunya adalah akademisi. Akademisi di kota Yogyakarta kita ajak semuanya. Ada Stikes Bethesda dalam bidang kesehatan. Kami dibantu melatih caregiver, melatih lansia agar memahami kesehatan yang benar atau merawat lansia. Lalu UGM, ada lagi UAD, UMY, yang terakhir adalah Fakultas Institut Seni Indonesia. Nah, seni saja sudah tertarik dengan lansia, yang kebetulan membangun grand design untuk layanan rumah layak lansia. Nah, di samping itu, non-akademisi ada Puskesmas, Posyandu, komunitas, MRC, gerakan sosial agama, masyarakat, dan yang lain-lain, termasuk OPD pemerintah. Nah, kami juga didukung dari Bappenas melalui teknologi informasi yang zaman sekarang harus mau tidak mau kita mengikuti. Di LLT itu sudah ada layanan namanya Silani. Nah, ini juga membantu kami kaitan dengan Silani ini memudahkan kami menginventarisir dan mendapat masukan keluhan dari lansia itu. Itu saja yang bisa kami sampaikan. Sekali lagi terima kasih kepada semua pihak. Harapannya dalam konferensi ini LLT juga bisa menjadi warna dan memberikan sedikit kebaikan khususnya untuk lansia di Indonesia. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Pak Andy. And one thing to highlight is that in terms of that local level coordination, that's your job. Yes. So he spends a lot of time collecting and really building up networks to support this. Okay, so in terms of, as has already been highlighted, there's an absolutely key role for BKKBN, and we're looking forward to Lude's reflections on some of the innovations from BKKBN in home and community care.
Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Namo Buddhaya, Shalom, salam kebajikan. Good afternoon, ladies and gentlemen. Thank you for the time given to me to share about the long-term care that has been implemented by the Indonesian National Population and Family Planning. Introducing me, Dr. Nilogde Sukaryasih, nickname Lode ya, Lode ya. To facilitate the discussion, please allow me to use the Indonesian language. Okay, thank you. BKKBN salah satu misinya adalah mewujudkan keluarga berkualitas. Untuk mewujudkan keluarga berkualitas tentunya semua anggota keluarga termasuk lansia itu harus diberdayakan, ya, harus diberdayakan. Lansia di Indonesia sekarang ada 11,75%. 2,58% itu termasuk kategori sedang dan berat. Jadi dari segi penilaian ADL-nya yang ketergantungan sedang dan berat. Nah ini adalah perlu caregiver atau pendampingan, perawatan pendampingan jangka panjang. Pendampingan perawatan jangka panjang, jadi pemberian bantuan kepada lansia untuk memenuhi kebutuhan dasarnya karena ketidakmampuannya, baik secara fisik, mental, psikososial. Sehingga di sini perlu caregiver untuk meningkatkan kualitas hidup lansia. Kami dari BKKBN dalam program kelanjut usiaan mempunyai kelompok kegiatan, yang namanya kelompok kegiatan. Kalau di BKKBN mengintervensi semua siklus hidup, mulai dari balita, bina keluarga balita, jadi namanya Poktan BKB. Kemudian remaja, bina keluarga remaja, namanya Poktan BKR. Yang terakhir adalah bina keluarga lansia. Jadi bina keluarga lansia dan lansianya. Keluarga yang mempunyai lansia dan lansianya. Jadi dari keluarganya itu kita berikan pelatihan, konseling, konsultasi bagaimana merawat lansia di rumah, terutama yang ketergantungan, ya, pendampingan jangka panjangnya. Kemudian apabila lansia yang termasuk memerlukan PJP itu, ya, tidak mempunyai keluarga atau anggota keluarga. Kami punya kader. Kader itu ada di BKL, di kelompok bina keluarga lansia itu. Jadi kami punya sebesar 296.528 orang kader. Nah ini aset kami sangat luar biasa ya untuk dimanfaatkan. Dengan 57.427 BKL, kelompok kegiatan di seluruh Indonesia. Kemudian kami punya koordinator yang mengkoordinir kegiatan itu adalah penyuluh KB. ya PKB dan penyuluh lapangan KB. Itu ada sekitar 60.000 lebih ya. Di setiap desa ada satu. Di setiap desa ada satu koordinator. Nah, di setiap BKL itu minimal ada 5 kader. Ya, ada 5 kader. Nah, ini permasalahannya apa? Jadi dari yang kami lakukan adalah pelatihan ya, pelatihan untuk kadernya melalui pelatihan langsung atau webinar dan melalui aplikasi Golantang. Jadi kami punya aplikasi Golantang, Go Lansia Tangguh. Jadi ada semua di Golantang, yaitu dashboard kesehatan. Kita tahu di wilayah kita, di desa kita itu ada berapa sih lansia yang mandiri, ada berapa yang ketergantungan sedang, ada berapa yang ketergantungan berat. Sehingga kita gampang untuk mengintervensinya, terutama yang memerlukan perawatan jangka panjang. Nah, itu yang kita lakukan. Kemudian di aplikasi Golantang juga kader atau keluarga itu bisa mengetahui tentang bagaimana merawat lansia. Ya, artikel-artikel yang terkait dengan lansia, entahkah nutrisinya atau perawatan luka atau perawatan penanganan kegawat daruratan pada lansia. Kemudian ada konsultasi juga untuk para ahli, kepada para ahli konsultasi, misalnya bagaimana menangani lansia yang depresi atau kesepian di rumah, seperti itu ada di aplikasi Golantang tersebut. Jadi kami siapkan seperti itu. Kemudian kader ini berasal dari masyarakat. Ya, berasal dari masyarakat yang bersifat sukarelawan. Nah, ini yang perlu kita bantu dari semua lintas sektor, karena kalau pemerintah saja sendiri seperti disampaikan oleh teman kami Bu Tirta dari Bappenas, ini harus berkolaborasi, terintegrasi sehingga kita bisa melaksanakan pelayanan kepada lansia itu, ya. Nah, ini untuk alur ya. Jadi bagaimana kami melaksanakan alur rujukan pendampingan perawatan jangka panjang di Bina Keluarga Lansia. Ya, untuk teknis tadi sudah mungkin disampaikan oleh Pak Andi ya, secara teknis sekali. Ya, sudah ada di situ. Nah, posisi BKKBN tentunya ada di koordinatornya, di koordinasinya. Karena setiap desa itu ada BKL, ada tenaga penyuluh KB-nya. Ya, itu di 1 menit. Oke. Ya, kader kelompok BKL dilatih tentang pendampingan PJP, kemudian anggota BKL-nya dengan indikasi PJP dirawat oleh caregiver. Yang ketiga, kader mendampingi lansia untuk dirujuk ke Paskes tingkat 1. Jadi kita bukan hanya memberikan bahwa nanti dirujuknya ke puskesmas ini atau ke rumah sakit ini, tapi dia mendampingi. Kemudian memastikan lansia ini mendapat ruang rawat inap. Nah, apabila selesai dirawat, ini kader menjemput lansia di rumah sakit ya, mendampingi, kemudian sampai pulang ke rumah dan memantau untuk selanjutnya. Lansia dirawat di rumah didampingi oleh case manager dan tenaga kesehatan. Jadi itu yang bisa kami sampaikan ya. Ini terakhir untuk alurnya. Nah, ini pelaksanaan pedoman PJP yang kita berikan oleh kader ya, kepada kader. Di sini sudah kelihatan ya, intervensinya semua, baik dari psikolog, petugas sosial, puskesmas, dokter gigi, organisasi lansia, fisioterapi, lab apotek dan seterusnya. Kesimpulannya, pelaksanaan PJP sangat perlu kerjasama dan kolaborasi semua pihak atau mitra sehingga kualitas hidup lansia bisa kita tingkatkan. Demikian yang bisa kami sampaikan. Saya tutup dengan Om Santi 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 Om. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Ludi. Thank you. And I think what we're getting is collaboration is absolutely key for providing these integration services, but also highlights quite how much innovation is happening here. So thank you so much for sharing that. We've really done a deep dive in Indonesia, but we are here in the Asia Pacific Conference, so we really wanted to give an opportunity to illustrate share some of the innovations from over the east side of the continent. So we're really pleased to have CEO Pelutu from Tonga to come and share a little bit of the experience, especially on caregivers, the experience of caregivers in Tonga and how the government of Tonga is responding to that. And then also, lastly, to look a little bit in Australia, who's really coming up a more established system, but also a system that's really finding quite a lot of gaps and how they're innovating to fill those gaps. So could we ask Nicole and CEO Pelutu to come up? Thank you. Thank you. Can we have a round of applause? Thank you. And we have a short video to start? Yes. Should we play that? So just a short video to give some context on Tonga. Thank you. So CEO Pelutu, she has quite a large portfolio in Tonga within the Ministry of Internal Affairs. She's responsible for women and gender equality, social protection and youth development. But today she's going to be talking about the government's response on aged care. So.
Good afternoon, good evening, everyone. So I don't know if there's been any Pacific representatives presenting in this conference, also the last 2 days. So I'm here representing not only Tonga, but also Cook Islands, Fiji, Niue, and PNG. So the presentation is about the caregiver assessment done in Tonga, which was supported through the Asian Development Bank's technical assistance. So this assessment was used in designing one of the components of the ongoing integrated aged care project, which is also being funded by ADB, Japan Fund for Prosperous and Resilient Asia and Pacific. In addition to the introductory video, you may wish to know that Tonga is a constitutional monarchy with a population of about 106,000 and about 150,000 of Tongan descents living outside Tonga. So Tonga has 171 islands, of which 45 are inhabited. And it is made from both volcanic and coral islands and reefs. And Tonga has a total surface area of 750 square kilometers, or 290 square miles, scattered over 700,000 square kilometers or 270,000 square kilometers in the Pacific Ocean. And it stretches 800 kilometers or 500 miles north-south. It also has an exclusive economic zone of 659,558 square kilometers or 657 square miles. So Tonga's population density is 145 square kilometers or 375 people per square miles. The life expectancy for male is 68.7 and female 74.3, but I think that was also in the video. How do you do the slides here? Okay, right. So the government in Tonga's commitment that all citizens of 65 years will receive proper services and financial assistance to ensure good quality of life so they can enjoy their twilight years in peace, harmony, and under God's mighty protection as embodied in the approved National Aged Care National Strategy Plan 2020-2024. The estimated population in Tonga over the age of 60 was 9.1% last year, and this is expected to reach about 12.9% in 2050. Insufficient aged care services, existing gap between care needs and services, high levels of non-communicable diseases, persistent levels of poverty, which is about 22.1%, and high levels of our migration of younger adult population means that the current care system is no longer adequate. Healthy aging opportunities and support to all our elders to age meaningfully and healthily will reduce financial and other burden on the health system. 19% of our elders were estimated to have one or more activities of daily living. It was estimated that 67% have at least one limitation in instrumental activities or daily living. 30% were reported as healthy without any chronic condition, with a lower proportion of females. 49% have low social support and at risk of social isolation. Of that percentage, there's more women than men. Cognitive impairment with associated deficits indicative of dementia is also common for about 20% of older people. Overall, 80% of the elderly had at least one need, with the proportion estimated to be higher amongst females, which was 83%, than males. The most common need among about 70% of the elderly population of Tonga was regular physical service. There was a growing number of informal reports of abuse and neglect, including instances of GBV, particularly within impoverished households. Climate hazards to intensify and become more frequent and severe due to climate change and worsen the impacts on older people's well-being. Caregivers are predominantly female, which is about 91%. Of those that were surveyed, 24% had never been married. 63% have upper secondary education. 65% had never had a job, while 21% were currently employed, with approximately 50% reporting work disruptions due to caregiving responsibilities. While some caregivers were spouses, 5.5% were wives and 1% husbands, Most caregivers were those from a younger generation. More than 3/4 of caregivers were daughters, which were 55%. Daughters-in-law were 9%. Granddaughters were 13%, and a small percentage were sons, 5%. Sons-in-laws were 0.3%, and even grandsons were 1%. A majority, 58% of caregivers reported having either some difficulty or much difficulty meeting their monthly expenses. Caregivers reported needing assistance with keeping the care recipient safe at home, learning more about the conditions the care recipient has, learning easy activities they can do with the care recipient, and assistance with talking to doctors or other healthcare professions. Caregiver burdens included feeling unable to control important things in their lives, lack of confidence about their ability to handle their personal, and never feeling that things were going their way, and feeling that things were piling up so high so they could not overcome them. The integrated aged care project in Tonga included 3 outputs. So as you can see, it had community-based aged care centers established. Output 2 was the aged care services and program implemented. And output 3 was the caregiver support and measures implemented to recognize, reduce, and redistribute care. And that is the focus of this presentation. So output 3 was the caregiver support and measures implemented to recognize, reduce, and redistribute care. So this included comprehensive support to caregivers, caregiving allowance, geriatric and caregiving counseling services, caregiving training certificates level 1 to 2, home modification assistance, ancillary supply support, and gender equality awareness program. In conclusion, Tonga appreciates the assistance of the ADB and the Japan government to enable this project for the integrated aged care for her aged population. The long-term aged care program is a response to strengthening and building the local workforce, as well as ensuring our aged population live a harmonious, resilient, fulfilling, satisfying, and healthy lifestyle in Tonga. Thank you, everyone.
Okay, so we just have one final short presentation. I think that really appreciate the Tongan, the really evidence-based and looking at the focus on how we really support families with a very comprehensive program. Our last very short intervention is really looking at Australia, which is obviously quite a well-developed system, but really looking at the trends there and really how they're adapting their home and community services to fill some of those gaps. And for that, we're really honoured to have Dr. Nicole Sutton, who's Associate Professor of Accounting at UTS, University of Technology, Sydney, from Australia. So over to you, Nicole. Thank you.
Thank you. And I appreciate that I am between you and your dinner or your evening plans, so I will try my best to keep this short and sweet. I think, as Meredith mentioned, Australia is fortunate in the sense that we have probably quite a mature home and community care sector, but it is poised for change. And so what I'd like to draw attention to you in the next few minutes is what have been some of the crucial challenges and gaps from the Australian experience, and then what policymakers are trying to do to address those gaps in the next version. So, like many of your countries, Australia's population is aging. We have numbers that are going up too. In terms of, but most Australians live at home, so 96% of older Australians live at home, and most commonly they live with their partner and their spouse. But importantly, the second most common household arrangement for older Australians is living alone, particularly for women. And that, again, creates a need for home and community care. And if we think about the sorts of things that older Australians need, we can see they increase with age. And they are things like, assistance with transport and property maintenance, as well as health. Now, to address those sorts of needs, just like I mentioned before, Australia's lucky in the sense that there's a relatively mature aged care or long-term care system, most of which actually service people at home or in the community. Over 1 million Australians receive services that are paid for predominantly by the government. Now, some of those programs include very basic home support, so things like transport and meals and social support, as well as more complex care, such as home care packages and nursing care. I'd like to draw your attention, though, to some of the other bits that kind of fall, but perhaps you might not be aware of, but Australia also provides things like respite care. So some of my colleagues today have mentioned how important it is to look after the carer. So Australia has respite services, and this provides short-term breaks for people to either allow them to have a loved one stay at a daycare centre or have someone stay in their own house so that the carer gets their needs met too. There's also things like transition care, which is helping people when they leave from hospital not end up back at hospital again, and short-term restorative care, short intensive programs to help people age in an active way so that they do not need other sorts of care services. But as I mentioned before, Australia has had some challenges. Okay, and I'd really like to spend a moment just pointing these out so that hopefully in your countries you can avoid these challenges as you develop your systems. Now, overall, I think we can see that most of older people's needs are well met, but there's still reports in terms of gaps, unmet needs in terms of the sorts of services that they need assistance with and they are not receiving assistance of. We also had a very big, somewhat traumatic Royal Commission, a big inquiry that pointed out a whole host of problems that emerge from fragmentation. So one of the benefits of having lots of services is you have lots of services. One of the problems is you have lots of overlaps and you have lots of gaps. Okay, and so you can see the sorts of challenges that arise when you have different programs grow and mature, and then you end up with fragmentation. It makes it hard to navigate. You might have repetitive assessments. It might be difficult to actually know what services are available. There's confusion about how much does the government pay, how much do I have to pay, and also, well, what is the quality of these services? What sort of information is available? And the other kind of challenge we're having right now in Australia is supply gaps. So we have an aging population and most Australians want to stay in their homes. So most of them want to receive home care, and we don't necessarily have enough suppliers to meet that demand. So I mentioned before that Australia is trying to address some of those challenges with what's called a new unified support at home program. What this is actually bringing together all the programs in Australia that provide home and community care under one umbrella. It's a very ambitious goal. It's been a goal for the last 10 years and it hasn't happened yet, but hopefully it will start next year. So the way in which it'll happen in stages, and that's simply because of the diversity that has to fall within that one umbrella, from very basic home support up to very intense complex care. But we'll see it roll out in stages. Now, a couple of the key features of this new program. One, and my colleagues spoke about this before, is the importance of assessment. So Australia is introducing a single assessment system so that older people do not need to get assessed and assessed and assessed again. They get assessed once in a consistent way when they enter the program for the first time, and then have regular assessments again in a systematic way. Other things come about in terms of helping older people understand what sort of services are actually available and what sort of prices are available and what sort of, how much they will have to pay, and also opportunities for them to self-manage so that they can choose a variety of providers to meet their needs. But the other thing that's important is that this is really about addressing the supply gap. So trying to encourage more suppliers, particularly from the private sector, to meet the growing demand for Australia's needs. And in particular, one of the main features of this program is a risk proportionate approach to regulation. So there's going to be 6 different categories of services that providers can register for. They can register for all 6, or just one category, or anything in between. And if they are registered for categories 1 through 3, okay, you can see what they are on the screen there, the regulation and compliance is much lower than if they're registered for categories 4 through 6. And it's with that, they hope to open up more of a market for the entry-level services that can build the sector sufficient to meet Australia's future needs, particularly in terms of providing care to older Australians in their own homes. Thank you so much, and I'll probably leave it there. Thank you.
Thank you, Dr. Sutton. I'm also very conscious that it is dinner time, and I know we have a very big group and we had a very, very diverse set of speakers. So I would ask if there is follow-up, and I think there was a lot of richness in the session today. We started off in South Asia, and then we really looked at some of the tools and assessments on how to bring this integrated care, with a deep dive into Indonesia, into some of the innovations, both at the implementation and the policy level. Then we travelled over to Pacific to really have a look specifically on that caregiver support, which is so crucial. And then thank you, Nicole, for highlighting, some of the challenges that even Australia has in really responding to this demand. And it's interesting, the integrated assessment came up again. So there's a lot of commonality despite the huge diversity of the case studies presented today. So I hope you enjoyed it. I hope you'll enjoy dinner or your evening in Bali. But I would like you to give all our speakers a round of applause, and thank you for joining us. Oh, we have announcements.
Just an announcement. Thank you for joining this session. It was very interesting. The announcement is that tonight from 6 to 8:30 p.m., there's a local government forum on older people's policies with dinner hosted by Bapanas and the Australian government through the Scala program in collaboration with HelpAge. And if you would like to attend that dinner, which I think that Pakatu Ballroom is the main room. Yes, yes. So it's down there, and if you want to go, you need to go to registration and get a card that looks like this, and then you can join the dinner and the local government forum on older persons' policies. I don't know.
Was it a help-page conference in Bali that ended up that she wanted to talk about the self-care on health for together, coming together with the... Yes, I guess so. I was in some foundation from year 2000 to 2020, 20 years. So I was... Maybe you organized me. Yeah. So maybe I might have met you. Yeah. So there were Indonesia, India, people from India. Because I went to her house. Kamu tuh Gustu. Gustu, Dodi? Bukan ya? Tahu semua. Nggak apa. Dia kan MKH juga. Gustu kayaknya di bawahmu deh. Mira. Oh, alah. Salah satu. Yang baru kan 2. Ini udah ada yang 2. 6 wajib 2. 2 udah.